So may I start the panel discussion with Alessio Agemo? So genotype 3 patients are now considered to be the most difficult to treat patient, especially those treatment experience and with cirrhosis. So what is now the new standard for this patient? Can you comment on this?
Yes. So I agree with what you said and also what Jean-Michel said, that in the past we considered genotype 3 patients clearly the most difficult to cure group of patients. Nowadays, I think we're getting to a point where we're close to what we achieved with the other genotypes. But still, it's a tricky genotype. So you have to look at more than just one factor when you look at treatment in these patients. You have to consider if they have cirrhosis, which is important because it's a negative predictor of efficacy, and you have to look also at previous treatment. So when you have a genotype 3 patient, you have to be cautious, and you have two options. The first option is sofosbuvir, which can be used as we recommended last year, which means that it's an optimal option, but for the cirrhotic patients, you have to use 24 weeks of treatment plus riba, which might be an issue in countries where 24 weeks of treatment have a high cost, of course, compared to a 12-week regimen. On the other hand, we have one of the new kids on the block, sofosbuvir plus ribavirin, which is just 12 weeks of treatment for the genotype 3. And also in the cirrhotics, it's just 12 weeks of treatment. But remember that once you use sofosbuvir ribavirin, once you have a treatment-experienced patient or a patient with cirrhosis, you have to use riba. And the reason is what Jean-Michel showed to you, that in these patients, there's a risk around 10-15% of having a baseline RAS, which basically lowers the efficacy of the ribavirin, and that is why we suggest you use 12 weeks plus riba in all the cirrhotics and also the non-cirrhotic treatment-experienced genotype 3 patients. But with these rules, you're able to offer your single patient at least 95% SVR.
What about comorbidities? Because some patients may have NAFLD or alcoholic liver disease associated. Does it matter, or will it change your regimen?
Well, genotype 3 has some peculiarities. Of course, it's associated with steatosis, which is derived from the virus. It's also associated, at least in many countries in Europe, with male gender, previous intravenous drug use, and often more severe liver disease. But what we know is once you get rid of the virus, there is a resolution or a reduction in the steatosis. So this is a reason why we should probably prioritize or treat the genotype 3 patients even before other genotypes. But basically, I wouldn't change my treatment paradigm based on comorbidities, no.
So do you think we have solved hepatitis C genotype 3, Alessio?
No, because we're still, I think, short of having an optimal regimen. For us, I think an optimal regimen is 8-12 weeks without riba, probably. Riba still has some side effects. Of course, it's not easy to use in patients with kidney impairment, in the elderly, so we still need a regimen possibly without riba. And at the moment, either you do an NS5A testing at baseline, and maybe then you can go without riba, or otherwise you still need to use riba in the most difficult group of patients.
But one of the problems is that drug development has just stopped. There is no more drug development. We'll see new drugs, next generation drugs coming, but basic research is no longer happening. And the next generation drugs all are with a protease inhibitor. So this may be helpful for patients without advanced liver disease, but I'm just afraid that we'll be in trouble in patients with Child-Pugh B or C cirrhosis who have genotype 3. We'll virtually have no other option than sofosbuvir, elbasvir, and ribavirin. And in these patients, we've seen that the results are okay, but not as optimal as they could be with other genotypes.
Yeah, you're right. I'm not saying we should wait for better drugs. I think what we have now is close to being optimal. And I think if you follow the guidelines, even if you're most difficult to cure genotype 3 patients, you're going to cure most of them. And you're right, we might have some salvage regimens in the future, but they'll have the issue with decompensated cirrhosis. So I would not wait for better regimens. I would treat with what we have now, all my genotype 3 patients.
And your gut feeling, are you happy with the drug classes we have? We have currently 4 drug classes. A few years ago when we started in this field and we were working on research, etc., there was something like 25 different strategies to address hepatitis C. Now we have 4 drug classes. We can improve them slightly, but do you think it's enough?
Of course, we would like to have even more drug classes, but you know, Jean-Michel, better than myself, that the other drug classes had some unexpected side effects. Some press releases have shown that some drugs which were targeting, for example, microRNAs have some unexpected side effects. Elbasvir had some unexpected side effects in its development. So I think we're at the point where we have to optimize the drugs we have in this moment. And I wouldn't count on having any new other drugs soon. Of course, if we're able to develop a vaccine, that would be very useful also for universal treatment and HCV elimination.
Personally, I miss the cyclophilin inhibitors. We have a paper that is published today on cyclophilin inhibition, Nature Communications. So I think it's still a very good approach for antiviral drugs, and it's very sad that we missed it because having one more class of drugs with a high barrier to resistance would have been fantastic. We will never have it, I think. David, would you like to comment on what is new in drug-drug interactions? We didn't see you when we arrived, so we're afraid you would not be here. And we're trying to find who could speak about DDIs, and everybody agreed that for us it's Chinese, and I guess it's Chinese for everybody else in the room. So we need you to translate.
So what's new in the guidelines in 2016 really is focused on sofosbuvir, elbasvir, and grazoprevir, elbasvir. And just the summary really of elbasvir. This is a drug which is very slowly metabolized, so metabolism is not the issue. It's transport with a protein, P-glycoprotein, and anything that will induce that protein or inhibit that protein can have an effect. So there's potential interactions with inducers, and there are a number of contraindications around inducers. And also just caution about some inhibitors that because elbasvir can inhibit P-glycoprotein, some narrow therapeutic index drugs like digoxin, dabigatran, there's caution with those. The other issue around elbasvir I think we have to face is proton pump inhibitors. I guess we've thought about this with ladipasvir, but there is an issue around elbasvir. It's acid sensitive. And so basically what we've said in the guidelines around elbasvir is that if possible you really should not use a proton pump inhibitor with elbasvir. If it's absolutely necessary, then there has to be separation and taking the elbasvir with food. The other thing that I think we put around elbasvir is in co-infected patients, we have to think about some of the interactions, again, which can be involving enzyme inducers. So some of the HIV drugs, such as efavirenz, atravirine, nevirapine, they are contraindicated with elbasvir. So it's not out of the wood as far as this new drug is concerned. With grazoprevir, elbasvir, if we look in the tables in the guidelines, again, we are going to see some contraindications with grazoprevir and elbasvir. And I just want to focus, in co-infected patients, again, there's some contraindications around grazoprevir and elbasvir because of the DDIs involving cytochrome P450, and also there's an issue around the uptake transporter into the liver, OAT1B1. So that's the sort of the main focus. What we've tried to do also in the guidelines is to separate in co-infected patients TDF and TAF. So you've got both TDF, which delivers tenofovir, and TAF, which delivers tenofovir, and they are different drugs. So we have to recognize they're different drugs. We've also tried to expand the boosted protease inhibitors, which are boosted by cobicistat, which is different from ritonavir. So we've had to expand some of the HIV as well.
David, are there any patients who take vital drugs and therefore cannot be treated with any regimen with HIV? Are there patients who cannot stop something which make that they are just not treatable for hepatitis C?
That's a question that I think I would find difficult to answer off the cuff, but maybe that discussion point will come up. I can't actually think of anything.
Yeah, I'm sorry we did not prepare. So
no.
Just came to my mind. I was just thinking it would be probably useful. We didn't write it in the guidelines, but probably useful to identify patients who just cannot be treated because they have some treatments because the question came with amiodarone, for instance. Can you replace amiodarone with something else? Yeah. And that's an example I have in mind. There might be other examples that make that in fact, you cannot treat a certain subgroup of patients.
I mean, I think with amiodarone, for example, we've tried to expand the amiodarone section in the guidelines, and grazoprevir elbasvir is really the option because it's not a sofosbuvir-based regimen, and we've been pretty strong, I think, in the way that we've handled the amiodarone and sofosbuvir-based regimens. We debated contraindication versus not recommended versus caution and all those sort of statements, which, sometimes are interchangeable, but we've been contraindicated as far as amiodarone is concerned. And then it's the stopping amiodarone. It's if patients on amiodarone to stop in the 3 months because of the washout period without a pacemaker, etc. So we try to put that into the guidelines around amiodarone as well.
What about the post-liver transplant setting and the immunosuppressive drugs? So maybe this is a question for David and Xavier as well.
I guess Xavier's got more experience directly, so it's probably better that Xavier speaks specifically to that topic.
Well, I think it is clear from the guidelines and from the experience in clinical trials that in this setting we have essentially to use an S5A inhibitor plus sofosbuvir because the PI, it's a disadvantage, clear disadvantage, because you have to adjust the drug regimens. So I think there's a lot of data, and that's what we say in the guidelines using sofos-based regimens, sofos-tacla, sofos-ready, sofos-velpatasvir, although the data is still coming up. The only thing I would mention is that it is nice to be aware that in some patients who are in the post-transplant setting, there will be changes in the levels of immunosuppression, though this is most an improvement in liver function, especially with acronymus, than a real drug-drug interaction. So I think the field is safe and we have enough options to treat well these patients.
So Xavier, can you comment on the 18-20 threshold we established? I think this has been based, there has been ongoing discussion, but we had the feeling that the field was almost reaching consensus without daring to write it, and we decided to write it. Can you comment on this threshold specifically?
I think we had a long discussion about that, and I think it's good that the guidelines have this threshold because it helps also people to make decisions. I think when you treat a patient who is very sick and has a very high MELD, the chances to get transplanted very rapidly are very high, though this patient will not finish treatment. That's one reason. The second reason, and you mentioned this in your slides, is that real-life data seem to indicate that the benefit in terms of liver function improvement, it's much higher in patients with a lower MELD than in patients with higher MELD. Maybe because we don't have time to see the improvement, or maybe because they are reaching the non-return point in their disease. And finally, safety. Treating a child puke C patient 12 points is a challenge. These patients are in the ward. They might have renal failure. They might come in and out from the ICU. So I think it's reasonable that the threshold we put. It might be argued that in some transplant lists where patients are transplanted with very high MELDs, this is a problem, not treating them before. But as you said, options after transplant are very safe, very efficacious. So I think we made a good decision.
Xavier, apart from the MELD, how would you deal with the timing of treatment? Because this is always an issue, whether you should treat your patients before liver transplantation or after liver transplantation.
I think we didn't really make a rule for that. I think if a patient is in the waiting list and has a relatively high MELD but not reaching more than 20, and you are able to improve liver function, and these patients get delisted, and Jean-Michel showed that 20% was more or less 15-20 what the 3 cities showed, you have more organs. If these patients get away from the waiting list, we have organ shortage, and that means that we can use this organ for another more sick patient. It is true that some people argue from an individual point of view that this patient may feeling in a MELD purgatory, the quality of life might not be good. In our experience, some of the patients that have been dropped out from the list are excellent. We have the ascites, no diuretics anymore, and doing normal life. It is true that these patients may develop complications afterwards, but we don't have enough data to really make a strong statement.
What about the patient with HCC on the waiting list? You usually have a low MELD score, and there is a 10 to 20% risk of recurrence and delisting while on the waiting list. How would you deal with this patient? Because this is always a tricky issue in clinical practice.
Yeah, I think you are right. Obviously, in patients with high risk of dropping out, it doesn't make any sense, at least in my opinion, to treat these patients, although in the rest of the patients, there's a benefit of that. We may discuss later the HCC issue specifically, but I think in general, I would say yes.
Okay, Massimo, what do you have to say on HIV co-infected patients? Anything new?
I think that there are no new thing. We have also in the previous guidelines, we have underlined that the treatment of patients with HIV is almost the same, with the same drug, the same schedule that we use in patients without HIV. This was, I think, an important point also for the community of HIV-infected patients, because this increased the access of this group of patients to treatment. And this is one of the group of patients where the screening for hepatitis C is almost universal. If you want, it is possible in a few years to eradicate hepatitis C in this group of patients, where the hepatitis C is one of the important cause of death, residual cause of death in these patients. So I think that our guidelines are...
You remember that it was even said that HIV patients responded better than non-HIV patients. I don't know where this comes from. There was probably a bias in recruitment, whatever. This is no longer...
Yes.
It's difficult to do more than 100%, yes. Right?
Yes. Well, this was probably due to the fact that the inclusion criteria for HIV-infected patient in registration trial was an HIV RNA negative. So we selected the patient with the best adherence. They were already adherent to the treatment of HIV, so this was probably the minimal decrease in response rate with suboptimal therapy, which were probably related to a reduced adherence, was probably not seen in these patients which were selected for adherence.
The good pupils, right?
Yeah.
And for acute hepatitis, it seems that we have an interferon-free regimen right now, correct?
Yeah.
So 8 weeks looks okay. Can we do shorter?
Yes, the problem is that the data that we have in patients with acute hepatitis are quite heterogeneous. First, because in clinical practice, the decision to treat an acute hepatitis can be taken, in most of the cases, after at least 12 weeks of observation, because a substantial amount of patients clear spontaneously the infection. So in some trials, patients have been included before 12 weeks or after the hypothetical initiation of the infection, after infection. Other patients were treated later. What we see from the data that we have is that in this case, HIV-infected patients seem to show a lower rate of sustained virological response. Studies performed in HIV-infected patients show generally a lower rate of sustained virological response if we compare the data with the patient without HIV. This was the reason why we were cautious to underline that patients with HIV and patients with high viremia can be treated also for 12 weeks. There is an important problem because in real life, in clinical practice, we treat acute hepatitis in some group of patients. Patients with a high risk of transmission of disease, such as healthcare workers or MSM with high risk behaviors, or in persons who inject drugs. So I think that in this group of patients, to develop an NS5A mutation associated with resistance could be peculiarly dangerous in terms of public health. We do not know, still do not know, if NS5A mutants can be transmitted from one diseased person to the...
They probably can.
It could be, because it has been seen
shown already with protease inhibitors.
Yes, it has been seen with protease inhibitors. So I think in this case, because we treat this kind of patient, resistance should be avoided with a stronger effort. And this is the reason why we probably promote an over-treatment of this patient. Treatment can be maybe reduced to 6 weeks, but I think that 8 weeks is a matter of caution.
In any case, we don't see many except some specific settings with high-risk groups.
Yes. Franco, could you tell us about the treatment of extrahepatic manifestation?
Yes, I'm willing to do so. Very challenging issue because actually the impact in terms of morbidity and mortality is quite significant. Also, as far as indirect costs are concerned, very often they result in major fatigue, impaired quality of life, work productivity, and I think they fully deserve our attention. The only issue actually with the symptomatic manifestation is actually how can we define them, first of all, and how can we grade them. The document you will see contains a referral to 3 major chapters. These are the vasculitis due to cryoglobulin deposition, the glomerulonephritis, of course, this is a classical manifestations, and the B-cell lymphoma. But when it comes to extrahepatic manifestations, the first issue we are facing is that we do not have an official list what is a manifestation which can be reasonably due to hepatitis C viral infection, and which may constitute a good indication when it comes to payers, for example. How can you convince payers to reimburse treatment for cognitive impairment, for example, or many other fatigue even? Okay. The first problem is we do need an official list, and I believe there is some work to do that. There is some bunch of literature working on that and focusing on that, but it probably is not the final word there yet. The second problem we are facing is that it's very easy to set a priority when it comes to liver disease stage, but when it comes to extrahepatic manifestations, we do not have official grading and staging systems. So when do we start treating fatigue, for example? We can measure fatigue, yes, for sure. We can have, all of us feel of fatigue sometimes during our daily life. Of course, we can grade our own fatigue. But when does it become significant in terms of treatment, antiviral treatment? How can we state confidently that we should treat that fatigue due to HCV? And the third problem is even more tricky. How can we define the causal link? Because many of these symptoms and manifestations are not specific at all. And again, I'm making an example of fatigue, and fatigue is a quite non-specific issue. So how can we expect a benefit when you treat with antivirals when facing a patient with feelings of fatigue? I mean, it may be depressed, and depression may have nothing to do with hepatitis C virus. This is an important issue because we need to know what to tell the patient in terms of expectations for out of treatment. And the other point, of course, we also to convince payers, again, that we want to treat this patient independently of the severity of liver disease just because of his manifestations. So I believe all these issues need some thorough discussion, some debate, and maybe we may even launch the idea of EASL promoting a debate, consensus conference, a specific conference on this issue, and coming up with a position paper. Maybe. I think everybody needs these kind of directions. We are very generic at this stage, I would say, but it's important what we wrote in the document are very generic, and nonetheless, because both healthcare providers and payers need some more detailed directions.
I think it's less important to prioritize treatment than it used to be because we are really currently moving forward to universal treatment. However, to push for this, to push for screening for national plans locally, part of the epidemiology and the impact of the disease is extrahepatic manifestations, and we generally count only liver disease, but the impact on the people and the society is probably much higher because of the extrahepatic manifestations, and we probably, because our bias is hepatology, we did not enough advertise the fact that hepatitis C virus infection is a systemic disease. And I think it goes for better screening, better access to care, better treatment in the future. So I think this is part of the epidemiology work. Definition first of what is considered due to hepatitis C, and then just counting, okay, you have X% of the HIV-infected patients who have cirrhosis, but you have Y%, and it's 3 times more, who have something which has serious consequences and eventually a cost for the society. And I think that would be probably very helpful. Jeff, would you like to comment on patients with chronic kidney disease? And I think it's pretty straightforward for patients infected with genotype 1 and 4, but I think people here in this room have questions about how can they use sofosbuvir and how to use it when you have no other choice. And this has been a long discussion between us.
So I agree, it's very controversial. I'm going to start, I think, with what is new in the guidelines that is less controversial, and that's the treatment of patients who've had kidney transplantation. So clearly we have a controlled clinical trial data which has shown remarkable efficacy. You've seen that data. This is a new deal for patients with kidney transplantation, which is very welcome. And it opens up the avenue of treating across all genotypes patients who've had renal transplantation and had chronic hepatitis C. There's still some concerns that come into that because, of course, you have to consider the immunosuppression in these immunosuppressed patients, as you heard before, but that's usually manageable. And then, of course, there is a consideration in the kidney transplant patients who may have, through long-standing hepatitis C, advanced liver disease, and clearly the protease-based regimens could be problematic in those, as you've heard before, in trials B and C cirrhosis. So those are considerations. But we've got controlled clinical trials which have provided good evidence. And also in the literature, there are now very large case series, in some cases 40 to 50 patients, who've been treated with a variety of DAA regimens post-kidney transplantation with excellent results. So that's new. The more controversial issue is the issue of renal impairment. And I would say throughout the guidelines, you will read no dose recommendation can be given for sofosbuvir, and that includes sofosbuvir plus ledipasvir, sofosbuvir plus velpatasvir, for individuals who have an EGFR less than 30. So that's clear. But in the real world in which you practice, and I know this is a common question, there are many patients out there with CKD, chronic renal disease, stage 4 and 5, on dialysis with chronic hepatitis C virus infection. I think the problem has more or less been solved for the genotype 1 and the genotype 4 patients because we have clinical trial data which have shown excellent results. The proviso there, of course, is the patients with dialysis who may have advanced cirrhosis as well, where it may not be possible to treat those patients with grazoprevir, elbasvir, or with Vicirax and Exvera, ribavirin, etc. So that's one issue. Then we come to the remaining controversial issue of the use of sofosbuvir regimens for the patients with genotype 3 in particular, but also 2, 5, and 6. And here I think it still remains vexing. We say use with caution, and I'll just in 1 minute elaborate what that means. I think clinicians looking after patients on dialysis with chronic hepatitis C have to take into account a number of considerations: the genotype, the stage of liver disease that those patients may have, the necessity to treat those patients on dialysis or to defer them and offer them renal transplantation, and as you have now seen, treat post-renal transplant. What would be the gain of treating those patients on dialysis? What would be the risks to those patients in using compounds out of license? How does one broach the subject with patients? How do we provide them with informed consent in the absence of a dose recommendation? I don't think we can solve the problem, but in the real world in which we practice, this is fairly common. And I think one would have to weigh up the individual risks as well as possible gains of treating patients and curing them of the hepatitis C. What would be the life expectancy, etc.? What would be the application later, should they be transplant candidates of receipt of a hepatitis C positive kidney? So I don't have an answer. It's very controversial. We are seeing more and more reports of the pharmacokinetics of sofosbuvir, and it does not appear that GS331007 accumulates. There seem to be obvious clinical toxicities, but this is a very careful and somewhat controversial clinical consideration, which I think only clinicians in expert centers can take on board at the moment.
Jean-Michel, what about resistance? As you mentioned, you're not clearly recommended to perform systematically resistance for obvious reasons for treatment access, but could you comment further on what is reasonable according to you?
Yeah, this is a discussion we had, and we gave it some thoughts, and it is important. You will always find people who will push for doing more and more and complexify and make things impossible. And there are people currently who are pushing for resistant testing for everybody, and the problem is that it's practically not possible and would just end up with limiting access to care, which is unacceptable. It's possible to treat patients well without knowing resistance. I think I showed it to you, and I hope there are other papers and review papers and other things that show it very well. Number two, resistant testing is not trivial. There are no kits. You cannot buy a kit. Those of you who are attending the conference tomorrow, I will discuss this. I will speak about it. So it's in-house techniques that have been developed by the virologist in his own lab. You never know exactly how it's been validated, how much trustable the assay is. And so with all this, it's not practical. And I think if we were to recommend HIV-resistant testing, the only consequence immediately would be that many patients would be denied access to therapy. And this is not acceptable. So I think with the recommendations we're making, not recommended, we explain to you how to treat patients without this information, but not recommended does not mean it's forbidden. If you have access to it, if you rely on the test, you can do it, and then you have other explanations to treat your patients with it. The only issue with not doing resistant testing is that you will slightly overtreat some patients. More patients will have ribavirin than the ones who really truly need it. Is it a big issue? There are side effects, obviously, but I don't think it's a major issue. So really we're trying to push for better access to therapy, and I think the guidelines are very reasonable in that respect. And the indications for possible resistant testing are very, very narrow and very well defined.
Could you also comment what is still the place for ribavirin in the new recommendation? Because there is still a place, and obviously this is more for treatment experience or in case of resistance.
Well, I think I summarized it on the last slide where I had these two columns. One was where you have no access to resistant testing, the other one where you have access. Ribavirin is for patients who are likely to fail. That's very simple. And these patients are treatment experienced patients of virtually all genotypes who receive sofosbuvir or elbasvir, 1, 4, 5, 6. It is for genotype 3 patients who are treatment experienced or have cirrhosis, and it is for patients who receive grazoprevir, elbasvir, are treatment experienced and eventually with cirrhosis based on the viral load as I've shown. And again, what resistant testing will tell you, if you have access to it, is less patients will receive ribavirin. In this group, you will select a subgroup of patients, the one who has the NSSA assays at baseline, who really need ribavirin. But again, if you don't have access to this information, it's not a big drama. You will treat more patients with ribavirin, you will achieve high SVR rate. I think what we learned is that it is very important with these NS5A inhibitor-based regimens that patients respond from the beginning. I remember what people were saying, let's say a year and a half ago, well, we will do shorter treatment, lighter treatment, and the ones who don't cure infection, we will retreat them. We now know that they are not easy to retreat, and that when you retreat them, you fail very often. You have to use combinations that are not very safe. You have side effects. It's not easy. So really, I think the message today is avoid failure from the beginning and use resistant testing only if you have access to it and be very comfortable without it.
So maybe before we take the Q&A from the audience, I have a last question for you and for the panel. How do you monitor your cirrhotic patients that are cured?
Xavier, that's for you. You're the cirrhotic man.
Well, I think it's clear in the guidelines, and there's actually no change. I think we have to do surveillance for HCC in our cirrhotic patients, and that's very important for centers in which patients are not followed in the same place and they're going to wait. They need high quality ultrasonogram for screening. I think that's very clear. For how long? That's the key question. I think at this time, forever, until we know that there's a point in which the risk of HCC is lower than what would be counseled based on the incidence of new HCC. So I think it's clear.
Okay. So thank you very much, the panel, for this very interesting discussion. I think we can... So we'll now take questions from the floor, questions and comments, and I hope you have questions. I have a few questions on the live chat, but I would really like to hear what you have to say and what you have to ask the panel. Don't be shy, please. The first question, which is that the 800,000 IU per ml threshold, is based on Merck analysis of their phase 2 and phase 3 data. And they were very kind on our request and without any information from our side on the guidelines for writing to provide us with this information and this data. I agree that the groups are small, but I think these data we could get, and I've shown you, are explaining where the split is, and they are very logical. And you really see that the only patients who fail are the ones who have the high viral load and the elbasvir assays. I agree with you that if the patient has 799,000 one day and 800,000 plus one the other day, may be tricky, but then guidelines are guidelines and your brain is your brain. I mean, you can make a decision. If you're close to 800, I think the safest way is to consider that you're above 800, and that's what you would do for your patient, I guess. Second question is for Alessio.
Just wanted to add a comment on what George said, because we have to remember that the cutoff is only for the subtype 1A and for the genotype 4, not for the subtype 1B.
Yeah, absolutely.
So it's very important to, so I agree with you. If you're near the cutoff and you're a subtype 1A or 4, you might be cautious. But if you're a 1B, there's no issue with viral load.
Yeah, 1B is all the same regimen. You're right, absolutely.
For acute hepatitis, obviously, the NS5A should be chosen according to the sensitivity of the genotype. So for genotype 3 in acute hepatitis, probably only the cuttoff and elbasvir can be used.
One question is, what for retreatment of genotype 3 experienced cirrhotic after failure of soft DAC ribavirin? Should we try elbasvir instead? The answer is you have nothing else. So as I said, it would be sofosbuvir, elbasvir, ribavirin, 24 weeks. That's all what we have, and if you fail, well, you may be in trouble and we'll have to wait for another combination. If you can wait for the other combinations. Pangenotypic. Second question for who wants to take it. What are the eventual risks and considerations to take into account to reduce the duration of treatment to 8 weeks? Who wants to take this one? Jeff.
I think the real-world data, as was shown in the treatment-naive, non-cirrhotic patients, is excellent. There are a few risks. I would ask Xavier, for example, in patients who are post-liver transplant and have recurrent hepatitis C, but do not have cirrhosis, have good liver function, are treated relatively early, would you consider 8 weeks for post-liver transplant genotype 1B patients, Xavier? Because that, to my mind, could be a potential risk. Should it be 12 weeks, or do they also qualify for 8 weeks? The other risk, I think, and I could ask, for the HIV co-infected patients who have F3 fibrosis, are we justified in treating them for 8 weeks? Should it be 12 weeks? What does the data show us? So I'm going to throw the question back slightly to those two.
The point is good, Jeff, but the answer is difficult. I think we need data. I think there are a couple of clinical trials, small trials, assessing if shortening the treatment in post-transplant, very early post-transplant, which is in some sense like an acute hepatitis, although we have the immunosuppression issue, might be helpful or not. I think at this point, I would say it's safer to follow the guidelines and not risk to have a patient, especially because remember that in post-transplant we are based on NS5A and we don't want to get a failure in these patients. But the question is well taken.
In any case, I think there is currently a consensus on the fact that less than 8 weeks you lose SVR. So 8 weeks would be the minimum for patients with chronic. For acute, it may be different, although I'm not sure. But for chronic, 8 weeks is a real minimum. I had this question, same question in Asia, so this is a problem in many places.
I think what we have to keep in mind is that even the post-transplant SVR rates are close to 100%. And let me tell you even more. If you treat FCH, fibrosing cholestatic hepatitis, I know the series are very short, but you can reach 100% SVR rate. So I would not be so worried of post-transplant. It is true. The guidelines do not really say you should not treat. What they say is it's better to treat patients with certain MELD score and not going above because of the risk that I explained before. I'm not saying you should not treat them. In living donor transplantation, in places where living donor is obviously a scheduled procedure, you can actually perform this treatment and schedule 12 weeks in order to finish therapy. That is true, and I think it's a good idea. But again, in patients who are very sick, child C patients, I think there's a risk in that to wait. So I would say, there's a good thing in having a procedure that it's scheduled and you know how long you're going to treat, but there's also a risk in putting a patient who is very sick under this drug. So I would say the guidelines are quite balanced in this point.
Thank you. So we have a question from the live chat, which is for me. Could you explain the resistance to NS5A inhibitors involving people who inject drugs? I think the issue is particularly acute, I would say, in people who inject drugs, because if you treat these people aggressively, which is recommended by different societies, including EASL, and you know that the rate of reinfection in this group is relatively high. I think these populations should be treated very well and with no chance of selecting resistant viruses. The only thing you cannot control is adherence Adherence depends on the patient, but you have to choose your patients well, motivate them well, and treat them when you're sure they will be adherent. Because there is a risk that if PWIDs are heavily treated, don't take their drugs well, select NS5A-resistant viruses, they will spread internally an epidemic of NS5A-resistant viruses that will become extremely difficult to cure even in newly infected patients. So I think optimization of therapy in PWIDs is extremely important, and people here who are treating these patients should keep into consideration that NS5A resistance is not tolerable in these patients. So we must succeed, they must achieve an SVR from the first treatment. It's very important. Yeah, I think what should drive the decision to retreat is liver disease or extrahepatic manifestation, the indication. I don't think we have enough information to know the best timing for retreatment. We know that the protease inhibitor-resistant viruses, they will decrease progressively and disappear. Does it change anything to the prognosis? We don't know. We know that the NS5A-resistant virus will remain forever at a high level. I think if the patient must be urgently retreated and you have a good retreatment, just go ahead and treat. If you don't have any urgency in treating, or if you wait for better treatments to retreat, you can also wait. So I would not give any firm indication on that. We don't have children and adolescents in our guidelines. I think if we are wrong, we should. There is not much information, but certainly in the next update we'll have to take into consideration. There are ongoing trials in children. But nothing enough to make recommendations right now. But I think this is something to consider for the future. Everybody wants to comment on amiodarone? David? Jeff? Jeff, David, Jeff?
Was the question on a cardiac assessment? I think it's good clinical practice. And we do say something in the guideline about baseline assessments, but I think it's good clinical practice to do a clinical cardiac assessment, and if necessary, an echocardiogram to look at structures, an ECG, the basic assessments, I think are good, particularly as we're treating an aging population with hepatitis C. So I think, yes, it is good clinical practice.
I have a very interesting, important question on the live chat, which is, if I find it, what are your thoughts about the use of generic HCV drugs, especially sofosbuvir, when patients are buying them with their pocket money? Who wants to say something? Xavier, Alessio?
There are access programs with generics, and just a brief comment, I think generics of sofosbuvir, elbasvir, and I believe sofosbuvir elbasvir are on stream quickly, more quickly than I think was the case for treating HIV. So that's progress. There are access countries with access to those generics, and I think that's important. And there may be a call, I think, for the other pharmaceutical companies to also make generics available in the future. We'd like to see that. I think that would improve our ability to work towards elimination of this disease. If the question is about importation of generics into the high-income countries, that's very controversial. There are a number of ethical, legal issues that pertain. You've heard the redemption study. Perhaps we won't go there tonight, but hopefully with proper acquisition costs, that won't be an issue.
Yes, so the issue here is really with the national regulation you have in your country. So in Italy, there was a court sentence yesterday saying that a patient who imported sofosbuvir generic from India and had it blocked at the airport, the judge ruled that a patient is allowed to import a generic drug for chronic disease, so now he can take the drug. We have to say that the safety and efficacy of generic drugs, which has been shown up to now, is close to being optimal. So I think the data shows there is safety. It depends on the national regulation. I can tell you that in Italy we proposed, it was proposed in the Senate to have a clinical trial with the generics in some communities of patients. So we hope to go forward with that in Italy. And obviously it's a way to shoot for universal treatment in our countries.
No, and I think that is the example. I mean, post the question, that is the example that I came up with. And I think, you've got experience in that. Is how many patients, does that actually apply to? It is the kind of patient that really is problematic if you're going to keep them on, if they don't want to go on to lamotrigine or another anti-epileptic drug. So I think that is the patient group.
Thank you. It was a very helpful comment. That was exactly what I was looking for, population. And you really have to balance the indications. I mean, what is more important, HCV or the other disease? And this is, thank you for that. We will have to dig into this. Thank you for the question, because I didn't have time to put everything, and it's an important one. I think we have been able to eradicate interferon from our guidelines. And we have also been able to eradicate HEV-RNA monitoring from our guidelines. And the guidelines say that you should test at baseline, logical, optional at week 2 or 4, not for efficacy, it's for adherence. So you're not obliged to test on treatment. The only obligatory testing for HEV-RNA are baseline, end of treatment, which is dispensable in my opinion, and SVR. So I think there is no room for monitoring viral kinetics on treatment. Every study has shown that with the DAAs, there is no predictive role of anything. You have patients who become negative very quickly and relapse. Other patients who have a slow decline of viral replication achieve SVR. You even had initially patients with sofosbuvir who were HEV-RNA positive at the end of treatment and achieved SVR. So I think we have to forget HEV-RNA monitoring on treatment. It's not useful, it's confusing, and really we're trying to simplify. And the other important message we had here is that you can replace HEV-RNA with core antigen testing. And this is just an ELISA. You must have the device, but I think there'll be other tests that will be coming in the future that will make it easier. So really simplification on this aspect. Who wants to answer? Adolescents, I think we already answered that there is no data and they are not in our guidelines, but this is something we must consider for the future and hopefully have a pediatrician help us draw some recommendations. Who wants to answer the other question? Alessio?
Soft grazoprevir, ribavirin. I don't see that personally as a reasonable option. I mean, the grazoprevir and the ribavirin have a very, very similar cross-resistance profile. And the ribavirin is not active on genotype 3 and also on genotype 2, some subtypes, it's not very active. So I don't see a reason for mixing two NS5As together, but maybe...
I even see many reasons to not mix two NS5A together. I think it would be a big mistake. I mean, the two drugs would compete for the same target. So you have to use these drugs according to the genotype specificity. The elbasvir is genotype 1, 4, 5, 6, and the cuttoff can be used for all genotypes like elbasvir or... I thought this question would come earlier than at the very last second. Thank you for the comment on generic drugs. There was a presentation at the EASL meeting which really supported the use of generic drugs. They appear to work as well, and the access to care is also affordability. And drugs have to be affordable. If we have good affordable drugs for countries that cannot afford the expensive ones, just go ahead and treat patients with these drugs. We have a question on HCC. I guess it's based on HCC recurrence, treating with DAA. And so, Xavier, would you like to start this discussion? But we had a long discussion on that until yesterday night.
Exactly, yesterday night. Yeah, I think if you read the text, we were quite detailed in the sense that we put the studies, including our own group study, in which we saw an association between HCC and recurrence after ablation or surgery and use of DAA, a temporal association, and other studies. And we also put in the text studies that didn't show an association between this recurrence and DAA. At this point, I think we have not enough power to have a general recommendation. So what we say there is that we just have to be aware of this potential risk. It might be true, it might not be true. Time will say it. But I think what we say in the final text is you can treat these patients. I I don't like the word you should. I think that should, I would put may treat these patients. But obviously, future studies may or not demonstrate an association. One thing I want to add here, because I think some people say they have a little bit of panic of this sentence, is that patients with HCC, their prognosis, but their vital prognosis essentially depends on the HCC. Some of these patients will be put in the waiting list and be transplanted, and you can treat them after that. So, I mean, in our center, we are delaying this treatment until more data are available, and we think this is reasonable because these patients, really, again, the prognosis depends on HCC. But, again, the recommendations are soft because the data are not conclusive. That's my opinion.
Okay, thank you, Xavier. I will make a general comment on that. I think it's a very good illustration of the dangers of the world that we live in, the modern world. A very good group makes an observation and reports in a journal an observation which has its merits and its weaknesses. It's a retrospective analysis. It's by definition biased. It's not powered. Immediately there is a buzz on the internet everywhere, and this creates a kind of panic because doctors read it and think they are promoting cancer. Patients read it, they're anxious about their outcome, and as their doctors call us, what do you think? And then you have a second paper, a French study from ANRS, which shows exactly the opposite. And at the end, we don't know. We don't know, but we created a panic. And this must make us think about the way we handle these things. So I think there are two options. Number one, the initial observation is true. If this is the case, it has to be demonstrated by a randomized prospective controlled study. It's very easy to decide to treat versus not treating and follow patients in a multi-center study. And we'll get an answer, definitive answer. And the other option is that it is not true and it's a lot of panic and issues for nothing. So let's take it as a lesson. Let's be careful. We already had the same thing happen 15 years ago when some people published that cured patients with HCV still had RNA sequences in their cells. I don't know if you remember. And there were hundreds, thousands of patients were told they were cured. We saw in the newspapers that there was a paper in hepatology saying that, in fact, they were not cured. And this created a panic as well. And we know now that the cured patients are cured. So this is my comment. We were uncomfortable with this. Jeff may add something. We were uncomfortable with this. We decided to be reasonable. We don't know if it's true. We don't know if it's not true. We recommend treating these patients if they have an indication. We recommend doing a clinical trial. And we added a sentence saying that unless treatment is harmful, which needs to be demonstrated, you can treat them. So we'll stay tuned and we'll see what happens. Jeff, you wanted to add something?
Yeah, I would just echo what the previous speakers have said, but I think if the data is wrong and it's spurious and it's taking us down the wrong direction, then what it's telling us is that we shouldn't be treating the patients at risk of hepatocellular carcinoma, namely the patients with hepatitis C and cirrhosis. And I really don't think that the evidence that we have tells us that we should not be treating patients with cirrhosis and hepatitis C, given what we're achieving at the moment. And we'll need good data. Perhaps there's an opportunity for a ethical randomized controlled trial where you treat some patients with cirrhosis and leave untreated others for a short time. But I think we'd have to think very carefully about not treating patients who are at risk of HCC with DAAs.
Yeah, and I think it is even just following on this, it's even the opposite. The data strongly supports treating cirrhotic patients. If you look at the SERVIR cohort papers, the French cohort paper, it clearly demonstrates that if you have an SVR and no metabolic syndrome, you have no HCC at all. So I think it's really demonstrated on a long-term follow-up study. Xavier?
Well, I have to say I do not completely agree with the French large cohort study, but that's obviously arguable, and that's a panel, and we all have our own opinion here. But I think one thing I want to say, Jeff, and I would disagree with that, I think what this is telling us is that we have to treat patients in a very early stage. I mean, it doesn't make any sense to have some countries restrict treatment to F4. What this all tells us is treat patients with F1, F2, F0, and then we won't have to do screening and we have this problem. So I think the main message would be that for me. And again, time will tell us what really happens with HCC recurrence. We're not speaking of naive patients in the guidelines. We are only speaking of HCC recurrence in HCC-treated patients.
I agree. Treat to prevent cirrhosis wherever possible.
Exactly.
So I think we'll all agree, number one, that universal treatment is the right way to go, and number two, that hopefully there are still unsolved issues, so we can come back in a year or so with the update of the guidelines solving all the issues we discussed today. So before giving the microphone to Laurent for the final conclusion from the Secretary General, once again, I would like to thank you for attending, thank the people who are watching us on internet there, the people who participate in the live chat, and thank the panel. It's a great panel, actually. Probably there are too many males in this panel, but I think we like working together, and the way we do it is entertaining, and I think what we've done is useful, and I hope it is useful, because this is the reason why we did it. So on this, I thank you very much, and Laurent, I'll turn it to you.
Thank you very much. So on behalf of EASL, of course, I want to thank the panel again, but also the chair for the outstanding work, and I think they deserve a big applause. Thank you. And looking forward to see you tomorrow.